Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
Good morning and welcome to Health Talk, sponsored by Mon General Hospital. Jim on vacation, filling in is Dave Wilson. Good morning, Dave.
Good morning, Kay.
And today I want to introduce Dr. Nabil Jabbour. He's an ophthalmologist. We're going to be talking about macular degeneration and the use of custom-designed eye injections. It sounds painful, Dr. Jabbour. Welcome to the show.
Thank you. Good to be here.
Let's start it off with, what is macular degeneration? That's going to be the topic. We'll start there. What exactly is that?
As I tell my patients, a mouthful, so I don't care if you repeat the name again, as long as you understand what it means. It means weak spots in the back of the eye.
That sounds pretty simple.
Yes.
And who would get macular degeneration? Is this an age process problem?
The majority of the cases are age-related. That's why the full name is age-related macular degeneration. Mm-hmm. Again, as I said, people over 60 are usually the most predisposed to that, and it's a very common problem.
But we can escape it? Not everyone over 60 will get it?
Not everyone gets it, but those who get it cannot escape it. It's a chronic disease. There's no cure for it. We just deal with the complications.
Could it lead to something even more serious down the road?
The simple way to think about it is like two separate stages, the dry and the wet. And again, I give the analogy to my patients. Think of your basement. If you have cracks in the wall, but when it rains you don't get water, you have cracks in the wall. It's dry. But if it starts showing wetness, then it became wet. Same thing with degeneration. You may have those cracks, the weak spots, for a lifetime with nothing else. The cracks themselves may cause some problems, but the majority of the problem comes when it starts getting wet.
Are there factors that can contribute to this disease?
Yes. Other than age, which is the number one risk factor, it's known to happen more commonly among Caucasians. There are many other factors, mostly nutritional, and that's why recently we have started giving people nutritional supplies.
Nutritional, you mean as far as our diet? We're not eating very well, and that would be unusual, I would think, wouldn't it, for Caucasians?
We thought so too, but studies have shown that there are certain supplements and vitamins that are missing that, if given in high amounts, can help decrease the severity of the disease. What
type of nutrition are we talking about? Is there a special vitamin that we would take? Do we want to eat more carrots? Is that the...
Yes, the old legend is correct. It's really not carrots, but there are multiple vitamins that we use in that formulary. But in addition, recently we have seen that lutein can help, and there's some xanthozanthines. It's called big name,
Big name.
But it's a big study called AREDS2, the new formula that people use in dry cases that could prevent them from going too wet. Not in every case, but it helps.
That sounds like a more natural way to proceed rather than immediately go into any type of a treatment. Is that more natural?
Correct, except it's not for the wet side.
Okay.
Those vitamins will do nothing after the wetness starts.
That's it. Well, then let's talk about some of the different types of treatments, and where do you start once the wetness is there?
If those cracks, as I said, start showing leaks, whether it's water or blood or both, which is the most common, in the old days, all we could do was laser, which was a wholesale kind of burn that would stop everything, but at the same time leave the patient with a big scar, very limited vision, until the pharmacologic treatment became available. And now, luckily, we have at least 3 very good possible treatments we can inject into the eye. Again, this is not a cure. This is a stopgap measure. It can help decrease the severity, reverse it for a while, and then we need to do some more.
So you're talking about stopping and turn off the bleeding and or the swelling. Is that through medication that we take by mouth, or is that some type of an injection?
It's an injection into the eye. Some of those medicines, to take enough of it to get into the eye, would be very toxic to the body.
Do all of them work immediately, or is this something you're going to have to trial and error with some of these treatments?
You hit the nail on the head. Those, if we think, let's simplify it. Let's say we have 3 different kinds that we can inject. whenever we see a patient for the first time, it's anybody's guess which one of those three is their best bet. There are no good studies to show I should choose A over B over C. We choose one, work with it, and then if it doesn't work, we switch to the other. That's part of the theme of what we want to talk about today, that we don't get stuck on one of them, even if it's not working.
Because some may work and then they'll stop working later on and you may have to try something else.
Absolutely, and that's also part of the plan.
Are the injections a one-time treatment, or is this something you'll have to come back periodically and receive over time?
It's a very good question because, as I said, there's no cure. So the idea of, we are spoiled with surgery, I think. If you have an appendix problem, you take the appendix out, you're done. One-time deal. As bad as the surgery is, no matter what, once you get through it, you get through it. Those injections are temporary. They work for a period. Average is about a month to 2 months sometimes. There's no rule. Everyone is different. But the truth is, none of them are a cure. So you have to come back and keep watching it, and whenever you need more, you get more.
Is it painful?
Also
Spoken by a man.
Yes, exactly. Usually men are more difficult.
Of course.
The truth is, every time a patient hears about it the first time, they're shivering. And they should. It's a needle in your eye. No one thinks about it as, it's okay. And right after we get done, the majority of the times what I hear is, this is it? Are you done? So I know I'm going to sound silly, but sometimes it hurts less than injecting a needle in your arm. But still, it's a needle in your eye, so we don't take it lightly. The complications could be a mess, but the pain really is very limited.
Is it a treatment where, I guess it would be an outpatient treatment? We come in, we can get the injection, and we don't have to stay in the hospital or anything like that. We can go home that day right afterward.
You don't even have to go to the hospital. We do this in the office. It's just go in, we clean up around your eye, give you the injection, and 5 minutes later you're out the door.
He makes getting a needle in the eye just so simple and easy, doesn't it?
Well, he makes it sound easy, absolutely.
When you do 25 a day, it should be easy.
It should be easy. What are the after effects after we go through this treatment?
The biggest concern we have is we're violating the integrity of the eye. By putting a needle there, infection is the first concern. We see patients 2 days later, make sure there is no infection. It's a very rare complication, but because it's very serious, we take it seriously.
Okay. When we come back from the break, we want to talk about some of the other options and how many times would we have to get the needle in the eye till you look at other options. 304-296-0041. We're visiting with Dr. Nabil Jabbour this morning. The phone lines are open if you have a question or a comment.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Talking about macular degeneration this morning and how you can treat that with Dr. Nabil Jabbour. And we're talking about the injections you can get into your eye it's not a permanent solution, but it does help. And there are 3 different injections you mentioned. And how do we know which ones to use, and how do we know which one's working and which one's not?
The second question is easier to answer. As I said before, we pick one. Let's spare the listeners that part. But let's say we pick drug A for you. The most important thing is to test it later. Is it helping you or is it not helping you? That is the most important question, because there are places and suggestions that you just get one every month regardless, which I think is not a very good idea to do that. Therefore, we test our patients in a month. If they are doing very well, they have responded fully to the drug, we wait another period, another month or 6 weeks. If they are not responding whatsoever, we start thinking about switching them to something else. And if they respond partly, that means this drug is working, but you need more of it, so we do more. As you can tell, it's just logic, not necessarily medicine, logic.
Can you actually switch drugs? Can one drug work and then over a period of time the effects wear off and you need to switch?
Yes, absolutely. It may not work from the get-go, then you switch. But it may be working. Like I said, it's working. Either you do more if you need more, or just wait and you do more again. But at some point you give it, and the response that you have been getting does not happen. And therefore, at that point, it's time to switch to something else.
In fact, Dr. Jabbour, you were telling me in the break of the amount of shots that or injections that you can get from West Virginia at Mon General compared to one of your patients, and it's kind of startling how many absolutely injections that people could get. You were talking about in Florida.
Yes. One
I
of
believe.
my patients told me that her friend in Florida, over the same period of time she was treated with 9 injections here of several years, her friend had 141 injections.
Oh my goodness! And that's where they continue every month just to do it before or
Exactly.
worry about the testing to see where they are.
They do testing, but for some reason, because the initial protocol was set by the FDA to do every month, but there was no study following that to show that you can do it less. There were some studies showing less to certain degrees, so everyone follows a different pattern.
Okay, and so once we've gone through the injections, as Dave has asked about, and we've gone through all the options, they're not working, then what do we do?
If all the injections available to us, and I should say here there are more coming up down the pipe, as you know, this is a big industry. If everything does not work, then we go back to some of our previous treatments that we had before. Right before the injections became available, a new kind of laser then was called new. We call it cold laser. It's called PDT, photodynamic therapy, was the mainstay for treatment. So we go back to that and do it as a rescue. And many times, patients who have that laser not only respond okay, they start responding to the drugs again. So it could be a double help. It still is a rescue treatment. It's not our primary treatment.
So the injections you would look as a safer type of cure or help than the laser?
The injections are now the state-of-the-art way of doing it, mostly because unless you get a side effect, they don't really cause the same damage or problems that lasers used to do.
Mm-hmm. I was reading some of the material about the lasers, thermal laser, the traditional one causing burns, and the cold laser. Can you explain that?
That's why I said the PDT, the cold laser, uses an injection that sensitizes. It's a photosensitizer, same stuff you use sometimes for tanning. Photosensitizes to a certain wavelength. And we inject that in the patient and wait a while until it accumulates in the eye where the bad target is. And then when you're shooting with a laser, you're more selective. The initial billing was it would be so selective that would be no damage except in the bad areas. You know, it's always good to not have secondary damage. But what we found out, there's always going to be some secondary damage. So yes, it is more selective than the thermal laser, which is totally non-selective, but not as selective as like it to be.
Let's go back to the injections. You said you worry about infections. Would there be any other type of a worry that you would have after giving injections other than that?
Again, we're violating the eye, so bleeding is a possibility. Very, very rarely that happens. We tell people detachment, which means separation of the back of the eye, can happen. There's always, with any treatment, there are always risks. Luckily, it's a very low risk.
If someone has macular degeneration, are they going to know it if they do not go to their eye doctor or their ophthalmologist?
In the dry phase and early on, they may not know it because it doesn't affect the vision in a significant fashion.
But eventually?
Eventually they do, and we give them certain cards to look at and things like that. But it's always a good habit for someone after the age of 60 to have at least one check.
We are talking to Dr. Nabil Jabbour about macular degeneration and the treatments for it. We're taking your phone calls as well, 304-296-0041 on WAJR.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
Macular degeneration is the topic this morning on Health Talk, sponsored by Mon General Hospital. Dr. Nabil Jabbour is in the studio today, and we've been talking about these injections and being, well, I guess you'd have to be a little patient to try to find what injection is going to work for you. And when you're going through these series, I'm sure you're telling the patient to give it time and not to get discouraged about it.
Right. I think the most discouraged patients will be the ones who are not doing well, and especially if they continue to get the same thing and they continue not to do well, their tendency is just to give up and not necessarily go from one doctor to the other. That's at least half a problem, but they just disappear from the system, and that, of course, their disease doesn't disappear, so they continue to get worse.
When do you know, though, that you have tried all the injections, when does the time come that you give up and try something else?
We don't give up. We try something else, like you said. Luckily, we have a very good test, which is called OCT. It's a big name again. But that test, which you have pictures in front of you, unfortunately, our listeners cannot see it. It's a very simple way of telling between that and the vision and what we look inside the eye for to know if the patient is responding or not, and gauge our treatment based on that. That's the whole idea.
And, of course, we're talking locally what you do, but this is a national study, you're telling me. This is something that's
We have presented some of our work nationally and internationally, and we have people following that algorithm. If someone wants to look at the article, we can give them the link. They can.
Yeah, that would be great. In fact, we'll try to get this up on the screen later on when we put this together, because you can watch this, Dave Wilson, later on Mon General's website.
Yes, you can. And, Doctor, does an individual's results, obviously it depends on the individual, but what are some of the factors that come into how well this treatment works for each person?
That's a very good question also, because the important thing for us to remember in medicine, every human being is different. And actually, in the same person, each eye is different. So we have seen different responses in different eyes. And in the same eye, different responses at different times. So you have to really, this is a custom-designed approach instead of a cookie-cutter approach.
But for the person who's on the fence and goes, I don't know if I want to get a needle in my eye, this could really dramatic just your overall quality of life, improving your vision, couldn't it?
Right. Most of the people just hesitated, and then went along with it because, one, they can read, they can talk to other people, they know that that's their best option. So ultimately they come around and try it. And after they have the first one, I have never had someone complain after the first one.
It could be a life changer, really. It sounds
sure is.
Like it could be a life changer. And this is something also, this process, we do not have to go to the hospital. We can do all this in your office.
In the office, correct.
Where are you located, Dr. Jabbour?
I'm on Collins Ferry, 3120 Collins Ferry Road.
Okay.
But we only take patients by referral. So if you have a problem and you don't know, go to your eye doctor. Then we have a bunch of good eye doctors. And if you do know you have that problem, you can call us.
Okay. And again, that's something you should do if you don't have this problem, but you need to go and see an ophthalmologist. You do need to go and get your eyes checked periodically. That's so, and even more so as we get older.
Yes, as I said, we have a good number of eye doctors around us, and go see someone.
How many patients do you see, kind of ballpark it, but with macular degeneration seeking this treatment?
A lot.
A lot. How many a day did you say you give these injections?
Well, depends on the day and depends what's going on. Could be up to like 20 sometimes.
That's amazing. That's amazing. So we do know that you can try different options. And to recap, the treatments and what's available out there, people, they have to ask the right questions. They have to come to you, get their eyes checked, and then go from there of how you're going to treat them. And it may take time. It's something that may not happen in one injection.
Correct, but we know how we're doing as we go. You're right.
Okay. Thank you.
Thank you
very much for coming in.
Here.
Dr. Nabil Jabbour, again, ophthalmologist, and talking about macular degeneration. You've been listening to Health Talk, again, sponsored by Mon General Hospital.